Hi everyone and welcome to my latest video, and today we're going to be discussing what is chronic pain. Now, the NHS definition for chronic pain is pain that lasts 12 weeks, so 3 months or more, and that's in spite of treatment and or medication. Now, it's important to note that not everybody with chronic pain is a permanent sufferer. So there are plenty of people out there whose chronic pain is caused by a specific condition, and when that condition is treated or effectively managed, the pain goes away. So to give you a couple of examples, many cancer patients suffer with chronic pain, and that might be because, for example, a tumour is pressing on a nerve, and if that occurs, then the removal of the tumour, whether that's surgically or through radiation or chemotherapy or anything like that, is going to have a good chance of alleviating the pain. Another example is somebody who has a degenerative issue with their knee, often as they get older, and that's when they start to look at doing knee replacements. Now, the degeneration is going to cause a lot of pain over a long period of time until it's treated. However, there is a very good chance that once the joint replacement is in and they've done the rehabilitation, and obviously the pain from the surgery and the rehabilitation is gone, that the pain will disappear as well. That being said, there is obviously a significant number of chronic pain sufferers who suffer with it permanently from when it first arises. Now, there are conditions like complex regional pain syndrome that can occur in people very randomly. So there are stories out regularly about people of all ages who, for example, might break an ankle or break a leg or something like that, and what seems as a very kind of innocuous injury to begin with, because obviously you break your leg, and if it's not a serious break, you go in a cast for 4 to 6 weeks, it heals, and you then get on with your life. However, some of them develop complex regional pain syndrome as a result of that injury. There's also a lot of conditions that cause chronic pain. So, for example, multiple sclerosis, fibromyalgia, Ehlers-Danlos syndrome, as per myself, and a number of others. Now, there's kind of two schools of thought with treatment of chronic pain. When I was 19, 20, 21 years old, so we're talking going back 10, 12 years at this point, and I was with NHS Tayside. So for those who don't know where that is, that covers Dundee and Perth in Scotland, and that's where I was at university at the time. They had a very medication-centric approach for chronic pain. So a medication-centric approach is exactly as it sounds. They prescribe opioid painkillers, they use nerve blocks, they use anti-epilepsy medications that have been found to be good for neuropathic pain, and neuropathic pain is pain that comes specifically from the nerves. Obviously, all nerves transfer pain and transmit it to the brain, but obviously if you have nerve damage, then that's where the neuropathic pain comes in. They would also prescribe certain types of antidepressants, drugs like amitriptyline and duloxetine, that were also found to be effective for neuropathic pain. And they would use drugs like lidocaine and novocaine. So if you've ever had dental work or local anesthetics so that stitches can be applied, then that's exactly those drugs, and they would inject them either specifically in an area to provide a period of relief, so it might be your lower back or your knee or your elbow or something like that, or alternatively they would put it in 2 big IV bags and you would sit in a room for 8 hours and they would pump it into you as a modified release version, and that basically means that it takes time to break it down, so you would get some pain relief for a couple of weeks. Now, there are issues with the medication-centric version. A number of people who suffer with chronic pain, it is a far more psychological and mental element to it than perhaps physical in their case, and obviously medication is not really going to affect that. You also have the issue of opiates, and we've got to be honest here, back in Nelson's Navy, opiates were used when they were cutting legs off people and arms off people, and back then they called it laudanum. Opiates do cause a number of problems. One, they are very risky drugs. They are respiratory depressants, so they slow the rate down at which you breathe. You also have the fact that your body becomes resistant to opiates over a period of time, and that's something I know myself. So you might have, for example, 50 milligrams of codeine to begin with is enough to manage the physical pain, but after a year you're taking 80 milligrams or 90 or 100, and then from there it just keeps escalating. And that's obviously assuming your condition isn't getting worse. That's assuming the pain is static. So if the pain is getting worse as well, because your condition is getting worse, they're going to have to increase it anyway. You've also got the fact that for certain conditions, so at the time they didn't know about my Ehlers-Danlos syndrome, certain drugs are not effective. So I mentioned earlier about the lidocaine and the novocaine. Those are not effective for Ehlers-Danlos sufferers because of the issues with our collagen and things like that, and how local anaesthetics react. And I wish I'd known that years ago when I was having dental work done, because it would explain why the local anaesthetics never really seem to actually fully block the pain when they're drilling into a tooth or trying to dig it out. So there's issues with the medication-based approach. Now, a couple of years ago, they started making major changes to the approaches at chronic pain units, because for decades it had all been about medication, medication, medication. And they now started taking a very non-medication, holistic approach, looking at the psychological side, the psychiatric side, the mental health side, and the physical well-being and mental well-being side. So, for example, there is a lot more focus now on providing people with antidepressants, talking therapies, discussing mindfulness, hypnotherapy, looking at alternative treatments like chiropractic care and acupuncture. Now, bear in mind, the medication-based approach did also look at acupuncture and chiropractic and TENS machines and things as well. But the new holistic approach, as I would call it, or the new non-medication approach, is, as it sounds, it's very much about not providing medication. They talk about things like pacing as well, diet, well-being, trying to get rid of bad habits like drinking too much or smoking or things like that. And this is a very effective mechanism for a number of chronic pain sufferers, particularly where it is a more mental and psychological situation. That does not make their pain any less real, and I really would challenge anybody who believes that because an element of it is in somebody's mind, that makes them not a sufferer. I would completely disagree with that, because if you look at it bluntly, that's their own mind torturing them, and I don't think many of us want to be in that situation. Now, for those individuals, and it made up a significant proportion of the chronic pain population, the medication approach didn't really work. So talking about pacing, which is basically saying to somebody, you shouldn't sit on your bum for 3 or 4 days at a time and then have one really busy day, because that busy day is going to cause a lot of pain. It's better to spread out those activities over 3 or 4 days. You know, conducting physiotherapy, art therapy, talking therapies, whether that's sort of individual counselling or whether that's group or whether that's both, they can really help a lot of people reduce their pain and get a better handle on their pain. And obviously there is a medication element as well in terms of trying to deal with any kind of depression or things like that, because it's been well documented and well proven that psychological illnesses and psychiatric illnesses and mood can contribute greatly to chronic pain. I mean, it's kind of obvious when you say it out loud, but if you've got a very low mood and you're not feeling great, then of course you're going to be more aware of your pain and more fixated on your pain, and that's going to make your situation worse. Now, the issues with this approach are that if you have patients like myself who have a significant or a major physical element to their chronic pain and their condition, these kind of therapies are not going to be overly effective. Now, I do practice mindfulness and hypnotherapy, and I do practice pacing where possible, because that's just common sense as far as I'm concerned. I've also done a lot of physiotherapy, I've done chiropractic care and things, I've used TENS machines. You know, I really have gone down the non-medication route entirely. The problem is if we use myself as an example, when somebody has a dislocation, and let's say that a random person has a dislocation in the street, a knee dislocation, you call an ambulance because they're on the ground, they're screaming, they're in agony, their knee's all bent and distorted, you're trying to get it back, it's not going back, the ambulance turns up, they're trying to help the person, but if their knee is not going back, they're then providing them gas and air, Entonox, which is a powerful, short acting but very powerful painkiller, and it also has the advantage of relaxing muscles, so muscles do tend to go tight and spasm when dislocations are out for a while. But if that's not working, they may then turn to morphine, particularly intravenous morphine. And they will give them intravenous morphine and then get that person as comfortable as they can and transport them to the hospital. At the hospital, x-rays might be done, a doctor will certainly look at the knee, and if it's still dislocated, then it's likely that they will be provided with more gas and air, possibly other painkillers. If it won't go back at that point, they will then have to take them through to the resus area in the accident and emergency, and they will then often inject them with a drug like ketamine to... Officially it's a painkiller. Unofficially, you still feel the pain, you just don't care. Somebody could light you on fire and all you'd think is, oh, that's pretty. They may even get to the point where they anaesthetise you. So that's the treatment for one dislocation. Now, if like me, you have lots of dislocations every day, or in my case 100 dislocations on an average day, mindfulness, art therapy, physiotherapy, they're not what the paramedics would do when they turn up to fix someone's dislocation. And that's for one dislocation. Now, of course, over time, you get more resistant to the pain, more capable of kind of focusing through the pain and trying to put your own joints back. And for those who aren't sure, no, I don't call the ambulance 100 times a day. In fact, I very, 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 very rarely call an ambulance at all. I put my own joints back. But for those kind of physical patients where you've done everything you can with the non-medication approach, but they're still suffering significantly because of the physical element of their pain, that's where those kind of patients need to be medicated. However, the current approach doesn't really allow for that. There's a lot of painkillers out there that can be used. Sadly, the overwhelming majority of them are opiate derivatives. However, because of where I am, Scotland, the drug death embarrassment situation, the Scottish Government has done a lot, and we'll talk about this in future videos, to restrict what GPs can prescribe to try and avoid prescription drug deaths, which are counted as part of the statistics. So the point is that many people will benefit from a medication-based approach. Many people will benefit from a holistic, non-medication based approach, and there are some people, like myself in the group, that really need both to be give them the most pain relief humanly possible. It's also worth noting, again, as we said, that not everybody who suffers chronic pain suffers it permanently, and there are a huge number of chronic pain sufferers out there whose chronic pain is manageable by them and them alone. It's never really discussed with their doctors. They're capable of managing it with over-the-counter medication like ibuprofen, aspirin, paracetamol. They might use some of the hot and cold rubbing gels or ice packs or hot water bottles when their back is sore or back is tight or something like that, as an example. However, the statistics from the NHS, and this is NHS Scotland as well as NHS England and the Office of National Statistics, make it clear that chronic pain is one of the biggest disabilities in the UK, and yet the funding involved and the treatment involved and things like that is incredibly small comparative to the overall population. So that is an overview of chronic pain. There's a lot of things that's brought up that we will discuss in future videos, but that is how chronic pain is assessed, looked at and treated currently in NHS Scotland, and from my previous experience and further research currently, how it's also treated in NHS England, over in NHS Wales and in NHS Northern Ireland. So thanks very much for taking the time to watch this video. I will be doing a video shortly on what Ehlers-Danlos syndrome is, because it's not exactly a household name of a condition despite affecting a lot of people out there. And obviously future videos on the political situation, issues with the NHS treatment, and my situation more specifically. Have a great day, thanks for your time, and do everything you can to fight your own chronic pain. Goodbye.